Welcome back to another episode of What Your Doctor May Not Be Telling You. Tonight's episode is on TRT. And if you're not sure what that means, it is testosterone replacement therapy, what men need to know before they actually get started. So thanks for being here. We appreciate you joining us every Monday night at 6 p.m. Central. If you get a lot out of this, please invite someone to join you next week. We repost on our YouTube channel all the archives, so you can always check those out as well if you miss an episode. So let's get started. I do have a special guest tonight later on. Hopefully he got the link, and he will be joining us to help facilitate questions at the end. So very excited to introduce you to a new member of the team. So low testosterone, there are some things that gentlemen need to know before they get started. And I want to tell you a story just to kick this off. I've shared this before, but it's just so poignant. So we got a call. We were in our old space. We had just started out, and we had someone call and say, hey, can you see this patient? We're on our way to the testosterone clinic to get pellets, but we'd rather come get them from you. And I just remember telling, intuition is such a huge part of medicine. I remember telling my team member, please, they're welcome to come in. I will take a look at their labs, but do not guarantee that we're going to treat them with testosterone and do pellets, because I need to look at the labs before we do anything. And so the patient came in and I did a consult, and the fatigue and joint pain and a lot of the things we're going to talk about tonight were some of the symptoms, but it was very cyclic and it didn't really correlate with the low testosterone. So I looked at the labs, the level was over 700. So this patient did not need testosterone. In fact, the patient had Lyme disease. And so if he would have gone to the hormone clinic, they would have been treating him for testosterone because, again, when they're a hammer, everything is a nail. So by coming to a clinic like ours, where we do functional medicine, integrative medicine, we don't have a horse in the race how we're going to treat you, because we have almost all of it. Or if somebody else has it, we will send you to them because we just want to solve the problem. So that to me is more important, to be at an integrative clinic that offers hormone replacement therapy than a hormone clinic. Big distinction between the two. So just as we get started tonight, keep that in mind. So there are a couple of warning bells that some men are aware of. So this dates back to the 1940s, that you can't take testosterone because of your prostate, and we'll get into how thin that evidence is. And then in 2013, there was a landmark paper that came out that everyone got scared away of testosterone because it raises your risk of a heart attack and stroke. So if you're a patient and on testosterone, don't follow the headline. You gotta know how I feel about that. Everything's nuanced. So this year in February, the FDA finally revised the first one. I think we have a lot of work to do before we revise the second one, but I think both are in order, and we will talk about why that is. So how did hormones even get on the stage? So this goes way back. This is in the way back machine here. So when you look at back in the 1800s, they were proving that there is a substance that circulates in the blood. So the concept of hormones dates back to the mid 1800s. And you can see sequentially, I'm not going to go through all of these, but they would implant the gland and thinking that the organ was what created the problem. Finally, in the early 1900s, they isolated from the testes testosterone and were able to inject it and use it as a treatment. So this goes back almost 100 years in the treatment. You can see dates back to roosters. So two of them were intact and they had the normal combs growing out. I think the combs are on the head. They castrated two of them and the combs shrank down. And then they took two and re-implanted the testes. And the patients, so they weren't connected to anything, right? They're disconnected. They're just freely floating in the body. And they actually regrew those combs. So again, this establishes further that this is a hormone. This is something circulating through the body. It's not the organ itself per se. Take that even one step further, and you just think how crazy they thought these people were back in the day. So this gentleman starts injecting himself with the extract of a dog and guinea pig testicle, right? You would end up in a loony bin. This is, when you look at the roots of medicine, it is not sexy. It is not super academic. It is usually some crazy person that tried something that would get you in a nut house for. But he said, hey, I am stronger. I'm better. I can pee further. Congratulations. Oh, it was an overall win. So this was just a placebo, which is interesting. But what it did again is came up with the concept of injecting men with something to improve their physiology and their function. So there are two different populations. There are the real treatment for men who are genuinely missing it. And that really, there's not just one bucket of that, that's a spectrum. And then there's the really scammy hormone clinics. To me, they rate about the same level as the scammy weight loss clinics, which is just hit men with a bunch of testosterone so they can go lift weights at the gym and be 25 again. We know every treatment has an upside and a downside. And so we need to balance both of those. So we need to have a very good reason before we start testosterone replacement therapy. I'm not going to get into a lot of this. This is how we started compounding and making testosterone. But where the word comes from, I think, is interesting. So testo for testes, sterol. And this is just the historical where it came from and how it became a manufactured drug. So, one of the biggest questions we need to ask is, do you actually have low testosterone? Is that, and I get asked this question all the time, is that high? Is that low? Is that okay? Where am I on that? So the average testosterone across a man's life, you can see starts low, peaks at just a few months, drops again through the toddler years, and as we all know, the dreaded puberty, it spikes up till they're about 18. So the 18 to early 20s is the highest arc, and then around age 30, it starts dropping about 1% per year. So we're talking about gentlemen who are on this end of the slide. Now, unfortunately, this is what it used to look like. I would make an argument now that based on a number of things, we are not peaking this high. I have men in their 20s and 30s that are down here in the 200s. So something bad is happening. This is actually an existential threat because these men who have low performing testosterone, they lack the masculine features, they lack the sexual capabilities, they lack the strength, muscle endurance, cognition. So we do have a real problem on our hands, and I believe it is multifactorial when you dig into it. So it's important to remember that most of testosterone is bound to a protein. So I think of it as like a boulder and it's stuck to the side of the rock, and that's how it goes through the bloodstream. Only the free testosterone that is not plugged into the boulder is available for us to utilize. So free testosterone falls even faster. So one of the things that we routinely check is something called sex hormone binding globulin. So this is one of those boulders or those big proteins that will suck up your testosterone. This is one of the reasons we use the product called DIM. DIM actually increases the amount of free testosterone while improving its metabolism. So, important to know that. So, when we check labs, we're usually checking as testosterone just to screen to start with testosterone and estradiol in men. As testosterone becomes estradiol as it leaves the body, so we need both. We have some men who are low testosterone but high estrogen. That is getting hung up in the metabolism and detoxification, and we need to figure out why. That could be a liver issue, could be a muscle mass issue, could be a detoxification genetic issue. We need to dig into that. So it's really important the time of day. Most of our patients do fasting labs, so we're going to be getting those early in the morning. Throughout the day, it can drop significantly. We're generally going to do more than one testosterone level also just to confirm. So the level isn't the end all be all, it is the guide that tells us. And then free T and sex hormone binding globulin together. So that's kind of the male hormone panel is you check all of them. So you generally want to have symptoms of low T and a blood test that confirms that is likely the problem. There's a lot of people who are exhausted and tired and worn down and don't have a lot of motivation that their testosterone is in the mid range or is just fine. And that's not the problem. Unfortunately, mainstream medicine, what do they say? You're just getting older. Deal with it. It's fine. We don't accept that at our office. I'm getting older is not an excuse to get you out of anything at James Clinic, unfortunately. So we know that over time, there are a lot of things this is tied to from a longevity perspective. So, obesity, metabolic disease, testosterone is an insulin sensitizer, messes with your sleep, just like women go through menopause. Men go through andropause, or if you're funny, menopause. Changes medications and environmental can be changed with medications and environmental exposures. So again, in the very conservative Midwest, we have some people who don't want to approach us about testosterone because they think it's mostly sexual. But 80 to 85% of the benefit you're going to get from testosterone is synthetic or systemic. It is longevity, it is performance, it's cognition, it's how well you perform at work, your attention, your focus, things like that. We need to remove that from the conversation or put that aside. I'm more focused on the systemic issues that we can improve with testosterone. But wait, there's the prostate. And doesn't testosterone cause prostate cancer? Ah, of course not. So, what is true and still is? So, men with metastatic prostate cancer, we know are given androgen deprivation therapy. That means we block the testosterone in those patients to improve their survival. Bad strategy, first of all. I'll show you where this came from. So, castration or estrogen made the tumor marker of the era fall, and the men got better. Hold that thought. This is actually still the backbone of treatment today. This is probably one of the areas I deviate strongest with standard of care medicine. I don't think there's any man out there that should have androgen deprivation therapy. And when we have patients come through our office, if they've already been started on it, they're much more difficult to treat than gentlemen who have not had androgen deprivation therapy. The problem is they created a this, if this, then that situation. So if low testosterone makes your PSA drop, we should lower your testosterone more. So that is not exactly the case when we look at this. So this is the analogy. If you're dehydrated, water saves your life, but that doesn't mean drinking more of it makes you healthier. Another analogy for this is think of a house plant. If you don't water the plant, so androgen deprivation therapy, if you do not water, the plant's going to shrivel up. But now take the plant, and what if I stick a garden hose in it for 3 days? I'm going to flood the plant. I'm not going to make it healthier. I'm not going to make it come back faster. So there's a problem with the logic in this. And I can tell you when a man starts androgen deprivation therapy, what we see is the PSA absolutely drops for about a year to 2 years. Then it takes off in a way and escapes in a way we can't treat. It gets really challenging. Oh, but wait. In 1941, this is the very flimsy evidence that this entire backbone of treatment in oncology is based on. In 1941, there were 3 patients that had prostate enlargement. So they castrated 3 gentlemen, they lost 2 to follow up, and they followed a test called alkaline phosphatase. And what they found in everybody did different. They didn't follow everyone, and the one that they did follow, they said did better, but his labs and alkaline phosphatase were all over the place. So that single paper, that single publication based on 3 patients dictated how every man is now treated. So again, this is why I deviate. This is the person I learned from. This is why I deviate so significantly for standard of care with my recommendations. Dr. Morgentaler is a urologist that really brought testosterone into mainstream medicine. So prior to the 1990s, this was something that was reserved for people who imagine gentlemen in a car accident where they were accidentally or traumatically castrated, or for cancer treatment, they had to have testicles removed, right? Testicular cancer, where they removed them, or I believe it was mumps that created some testicular swelling. So there were medical reasons that these people were on the outliers of normal. Dr. Morgentaler really made this more mainstream for gentlemen and said, hey, this is going to make you feel better. It really is the anti aging, if you will. It makes you stronger, think faster, good for the bones, muscles, heart. We're going to get into that. So he really brought this into every man should be offered this treatment. But then that conflicted with the prostate cancer information. So in 1996, there were 77 men with low testosterone, normal exams, and a PSA under 4. 11 of those 77, so 1 out of 7, was that 14% or so, had prostate cancer despite a low testosterone. So In 2006, he actually went back and said, I really would like to see what this is based on. And he published the historical perspective on a modern myth and said, this is really not the evidence that we thought it was. This is not what we've been told. So in 2006, he looked at 345 men with a PSA under 4. And what he found is the rate of cancer in patients with an adequate testosterone level over 250 is the cutoff was only 12% versus in below 250 was 21%. So this should be echoing if you were on last week. Remember, women with estradiol levels and estradiol replacement had lower breast cancer incidence and better survival than those who didn't, who had low estradiol levels. We're seeing the same thing with the men. So clinics like ours, again, we swim against the current, doesn't make us wrong. So in 2008, 18 prospective studies were pooled. There was no association between the man's own testosterone, DHT, dihydroxytestosterone, which is one of the metabolites, estradiol, the downstream metabolite, and the risk of prostate cancer. 18 prospective studies. So this is a meta-analysis. This is a big deal. So castration may shrink prostate cancer. Androgen deprivation may shrink prostate cancer. It's going to put a man through menopause. So if you thought a woman with hot flashes was bad, try having a man with hot flashes. I think a cold is bad. Higher testosterone does not cause it, and lower testosterone may be the more dangerous state for progression and aggressiveness of the testosterone cancers. So how do we explain that? So this is the saturation model. So what we know with serum testosterone is the saturation point is around 200 or 250. So if a man is below 200, that receptor is going to be responsive to the level of testosterone. But over 200, we're not going to make that tumor grow any faster because all the receptors are saturated. So it can't do any more. So think of it this way. If you had a hallway with a bunch of doors and you had 6 keys, you're going to put all those keys in the door and you're going to unlock some of the doors. But if you had 75 keys, you don't have 75 doors. Same idea. Bad analogy, but same idea. Below 250, the tumors were exquisitely sensitive to testosterone, and above, it's indifferent. You make someone feel better though. So again, a dry houseplant responds dramatically to water, but once it's watered, pouring more on does not make it grow faster. So this is a Morgenthaler analogy. So there's even better data. So the Traverse study in 2023 looked at gentlemen, there were over 5,000 patients who were put through the study on testosterone replacement therapy. So all of these people were closely surveyed with labs every 3 months, I believe. They were treated only 2x the normal testosterone level. All of them had existing cardiovascular disease, and it was about a 3-year study. And so every single person whose PSA popped over 4, who had a digital rectal exam that showed a mass, or who had abnormalities on imaging was biopsied for cancer. So they found the sickest cohort of people to put in this 5,000 study. So if giving them testosterone caused prostate cancer, you would anticipate seeing an increase in prostate cancer rates. But they didn't. They did not. So 12 versus 11. So we can come to this conclusion that this is the testosterone, excuse me, that was a placebo controlled study. So on the placebo, you had the same number of cancers as you did in the treated arm. So what about the heart? So this is actually probably the most important thing. I think this is still out there. So in November 2013, again, this kind of echoes what we talked about last week. There's so many parallels. In 2013, JAMA announced there's a 29% higher rate of death, heart attack, and stroke in patients using testosterone therapy. This was men from the VA system. So we know these are the toughest patients out there who had coronary angiograms. And again, lit the world on fire, changed how everybody practiced medicine. Testosterone wasn't super mainstream anyway at the time, but the treated men did half as badly. So they did twice as well. So they flipped the numbers in the statistical analysis and oopsie got it quite wrong. So there's actually a 29% higher rate of death, heart attack, and stroke in the group who didn't get testosterone. So the data, again, 10% increase or 10% event rate with testosterone over a 20% event rate without. So they actually did much better from a cardiac perspective. And if you think about what testosterone does, it actually increases perfusion. So it vasodilates and increases blood flow to the heart, reduces ischemia. So they got it wrong. They didn't ever print a retraction. They printed a correction in 2014. They never really retracted the study. So that stands out there incorrectly. It's not the case. So if we have somebody with unstable angina, I actually would recommend that we treat them with testosterone because we're going to increase the coronary perfusion. So again, JAMA, so all of these, 29 societies, 160 physician scientists in 32 countries said, hey, you got this wrong. You need to come back and correct it. This is why when people ask me, what does the data say? I take that with a grain of salt because the data was so wrong in so many places, and you really have to know where to look to know what they got wrong and how they got it wrong and why. So again, for 10 years, men went untreated because the powers that be thought that they would have heart attacks and strokes. So in 2014 or 2014, the FDA got involved with communicating safety. A year later, the cardiovascular warning went out. So remember, we just removed that from the women's products. It went on the men's products. And the lawyers aren't far behind any of these declarations. Are you a man who was started on testosterone therapy and had a heart attack? So that's how we ended up with standard of care the way it is. So the testosterone versus placebo, we're looking at a 7% incidence versus 7.3. So if you treat enough men with testosterone, some of them are going to have heart attacks because some of them are going to have heart attacks without that treatment. So this isn't necessarily going to stop that from happening or block it, but it isn't going to cause it. So in 2025, again, Marty Makary did the same thing, came out and removed the cardiovascular language from the black box warning on testosterone and changed the way it should be prescribed. There are a few risks associated with testosterone, AFib, acute kidney injury, PE, and I don't know why they would have had more fractures because really testosterone is good for the bones. So I'm not sure where that finding came from. I'm not sure about the rise in blood pressure. I would say there can be a slight rise in cholesterol the first 3 to 6 months, but that usually levels out by month 6 and actually improves after that. So, testosterone does not cause heart attacks or strokes, but patients who are going to be treated in this category are going to have those events anyway. All right, so what does testosterone help you with, and what does the data say? So there's a few reasons to do this. Obviously, the sexual function, so the libido, erections, activity, performance, all are going to improve. Body composition. So if you're looking to lose weight and your testosterone, depending on your age, is below 500, this is definitely something I would look at. It will help you bulk up or improve your lean muscle mass and reduce body fat. Anemia, this is interesting. When we treat with testosterone, there is a side effect called erythrocytosis. So that is an increase in hemoglobin levels as a direct effect of the testosterone. This is what Lance Armstrong was doing in the doping. He was actually giving himself testosterone, raising his hemoglobin. I believe this is the tie. And when you have more hemoglobin, you have more oxygen carrying capacity, you have more ability to perform athletically. Increases bone density. So I don't know why all those fractures were there in the last study. And then it sensitizes insulin receptors. So men with optimal testosterone, their metabolic health is much better than men without. I would say mood is going to be a huge one. I don't know how many gentlemen tell me I got motivation, I got up off the couch, I wanted to go work out, I had all this energy. So it is helpful for mood, depressive symptoms, things like that. I would say it could be a replacement for treating depression. So if someone has severe depression, you do have to watch those patients. I wouldn't do this in isolation, but if somebody just has a little melancholy or seasonal affect, this definitely can help. So the cardiovascular benefit, It's not supported, but I do think with more people who are inclined to design studies that will show benefit, it would be there. Also, cognition. We definitely see this with women that cognition is better. I'm going to say that there may not be data to support it, but it makes sense and I would do it for cognition. But what do you need to know before you start? There are some important things gentlemen need to know. You don't just go do this willy-nilly. There's some important things. First, we want to understand the cause before we just go replace the hormone. So, especially with sleep apnea, it can make sleep apnea worse. So, we want to get that tested ahead of time, especially if the neck circumference is, I think it's over 18 inches. We need to get a sleep study, screen for sleep apnea, make sure that's not a problem. If someone has active liver disease or is an active alcoholic, this is not where I would start with things. Again, opioid abuse, because basically, if you haven't optimized the body and then you throw this great treatment on it, the patient's not going to appreciate that. You're swimming upstream, you're swimming against dysfunction. So you've got to correct those underlying things and then deal with this. Chronic sleep and overtraining. So if you're overstressing the body, adrenal fatigue, you are going to hit your testosterone. So there's something called the HPA axis, hypothalamic pituitary axis. So your pituitary gland is in your brain, your thyroid gland, your adrenals, and your sex hormone all kind of interplay together. So if somebody is under an enormous amount of stress, that is going to deplete testosterone very quickly, whether that is physical stress of overtraining, mental and emotional stress of major life events, losing a job, losing a person, things like that. So, even if we treat testosterone, we decide that's in the patient's best interest, we have to know why so that we can help deal with that issue over here. The next one is a big red flag. So, and I usually ask this with no presumptions, by the way, are you planning on having a family? So, I don't assume if someone's over a certain age, they no longer want children. That is a dangerous assumption in this day and age. But if a gentleman is on testosterone exogenously, so if we're injecting it or giving it in pellets, that suppresses spermatogenesis or sperm production. It is usually reversible, but not always. So it's a 90-day on ramp. And after stopping treatment, which with pellets would be 6 months, is a 90-day off ramp. So we're talking a year minimum. And if a young gentleman wants to do this, I'm going to get a sperm count ahead of time to prove where we started. So that is definitely something. If someone is family planning and wants to have additional children, we're probably not going to start with just giving testosterone exogenously. We're going to start with something else. So know which route you're choosing and why. So I have very strong opinions about this. I am very much injections or pellets. I do not like the gels, the topicals. We will not do oral testosterone in our clinic. And I've never heard of nasal. So injections or pellets are your two options. If you want to get topicals, go somewhere else. I think it's a bad treatment. I don't do it. This can be a long-term commitment. One of the big fears patients have is if I started, I have to commit to a lifetime on the treatment. So you have to commit to, if you feel a lot better and you want to stay feeling a lot better, you might have to continue the treatment to feel that way. If you don't want to continue treatment, you'll slide back to the current baseline and that's where you'll be. So you may, if we're suppressing your testosterone by treating you externally, you may dip a little bit and then rebound to where you are before you start, but you do not have to do this forever. And the goal is replacement, not maximization. So we are going to individualize that. Generally, I'm going to try to get the testosterone level from where it is to 900 to 1200. That's kind of the sweet spot. Now, some men feel better at 1300. Some men are absolutely fine at 700. So we're going to individualize that. And it's not just I want to pump you up in the gym. That is not what we're going for here. We're going for physiologic improvement and benefit. So again, testosterone you take from the outside shuts down spermatogenesis. It is usually reversible. So I do actually have someone in my circle that they got pregnant while on testosterone treatment. So it absolutely can happen. There are some things we can do to try to preserve fertility. It's not a guarantee. So if this is something that's important and a priority, we need to know that ahead of time so we can factor that into the discussion. Whether it's giving things to just boost your own production of testosterone or replete your vitamin levels or address the mitochondria, we have other ways to do that if this is the top priority. So again, the first two are the only two I offer in my office. So injection, I used to be pellets only. Pellets for a man who can't sit still are not a great option. So for the gentlemen who work all the time, won't sit still, I've got a farmer, I've got a military person, bodybuilders, they will not stop. And what happens is they've got movement and the pellets just kick back out the tract and they kick them out. So for them, injection is better. They need to do this once or twice a week though. Pellets is every probably 5 to 6 months. It's a little bigger procedure in the office, hurts for a couple of weeks, and then easy peasy. The rest of these we won't even talk about. So we must monitor if we're going to do this treatment. This is a medical therapy. We do have to monitor. So total and free testosterone, we need to know a baseline PSA and a PSA every 6 months thereafter. A metabolic panel and lipids, which we already do. We're watching that hemoglobin to make sure it doesn't shoot up. If we do have a man shoot over 18 with a hemoglobin, that causes a traffic jam with the blood cells. So we've got to do some what's called bloodletting or therapeutic phlebotomy to pull those, reduce that blood cell count so we don't have a traffic jam with the blood cells trying to deliver oxygen. We're going to watch blood pressure and we have to look at estradiol. Sometimes men peak out a little bit on their testosterone, their estradiol shoots up, and we can see things like breast or nipple tenderness, breast enlargement, hyper emotionality, male pattern baldness at the top. If we start to see those, we need to do some internal tweaking on how the body metabolizes testosterone. So we are going to check the first round of labs at about 6 weeks after starting, then around 3, 6, 12 months, something like that. We're going to keep that whole protocol going. So really important to remember that just because something is entrenched in modern medicine doesn't mean it's on the foundation of good science. So there are so many things that have made it into mainstream and even now patented drugs in the androgen deprivation world. They just stack them one on top of the other now. Hey, if this one didn't work, do this one, now do this one. And they continue to layer them without looking at metabolism, without looking at the effects. So you can have a situation in which castration or androgen deprivation works to reduce the PSA and also replacing it is safe. Both can be true at the same time. And that's going to be really hard for the medical establishment to accept because they feel like it's one way or another, but not both. And the Traverse trial was designed by the regulators to find harm in testosterone treatment and did not. Didn't find cancers and didn't find cardiac deaths. Important to know. So, if you've been told no for various reasons, we want to have that conversation. We can be quite a bit more nuanced with how we prescribe testosterone. It is not safe carte blanche, it is not dangerous carte blanche. It is like everything else we do. It has some good, some bad, and some uglies. And we just need to know who to do it for and why to do it. So, all right. I am going to bring Matt up. I want to introduce you to Matt Fleshman. He is not here to talk about his testosterone levels. He has joined the James Clinic team as a business manager. He's helping on the marketing side of things and just making sure you and all your people know about us. So Matt, welcome.
Hello, how are you?
Good. All right.
This was interesting. It was very good, very informative.
Yes, there's a lot to testosterone. I think is sold to men as a pretty straightforward, hey, come get it if you're getting older. And I think there's a lot more to it than that to do it well. Are there any questions out there? Or Matt, do you have any questions off the top of your head?
I have an observation actually. It's interesting when you were talking about my father actually had gotten prostate cancer years back, and you were talking about withholding hormone, which was the treatment that they did
Mm.
for him, plus some pellets. And one of the concerns that I had, and I had said that my father has gotten sick over the years, is diabetic, right? cardiovascular issues. And without having estrogen and other things, I'm wondering if the advancements that kind of has rendered him today with extreme muscle weakness, he's had fractures, coronary art, just so many challenges. That's not one of the causes as to why it concerns me since I'm 50 now.
Yeah. Yeah, it definitely, again, I'm so against androgen deprivation therapy for men. It does terrible things. They may live longer, but they'll wish they were dead, is what I tell them. I feel that strongly about it. The question we don't know is, when is it safe after a prostate cancer diagnosis to replete? And I think give us a year or two, and I think we're going to be at that point where we'll tell you exactly when is okay. There are literally people on this call that have been told they're going to die by not doing what I recommend, or by doing what I recommend, they're going to die. People on this call tonight have had that information. It's not true. I think they've come to understand that, and yeah, have a little more nuanced approach to this. All
You know,
right,
if
question.
anything else,
Yeah.
if anything else, men over my, I'm 50, men over my age, we should be looking at our PSA, right? We should be getting screens. One of
Mhm.
the things that I just on the surface see this as a benefit is a lot of the male things that we should be doing. We tell our wives, you should be doing this and you should be doing that, but we're not doing the things we should be doing at our age. That's kind of a hidden side effect
Agree.
of watching our testosterone, looking at PSA levels, a metabolic panel, all
Yeah.
the things that are going to impact our health. So it's kind
Mhm.
of a hidden gem.
Yes. Gary Scott, go ahead. You should unmute and you should have the microphone. Gary, did you want to ask a question? Maybe he bumped it. I'm going to go ahead and answer this question. And Gary, if you did, we'll come back to you. A family member was diagnosed with Graves' disease. Could a high or low testosterone level be causing symptoms also? Trying to get him to call your office, doesn't seem to find a doctor here to really care and dig a little deeper. Yeah, that's the problem with the system, is they have their little roller coaster and you just need to hop on and follow their lead and they'll take you where they want to take you. The thyroid and the testosterone can be related. I can tell you again, if a person is under a lot of stress, it's going to knock out the thyroid and knock out the testosterone as well. I can also tell you, if we replete testosterone and hormones or thyroid, and then we add the other one, we have to, if I get thyroid dialed in and then we add testosterone, we usually have to readjust thyroid, and the opposite. If we get the testosterone dialed in and we add thyroid, we usually have to make adjustments either way to get it all evened out. So hopefully that answers. Graves is more of an autoimmune condition, so I'd want to know a lot about the gut issues and what's going on there and treat it more like the inverse that we would treat Hashimoto's. So I hope that helps. Gary, did you figure out your mute button? There we go. Caller number 9, Gary Scott. I can't hear you, Gary. Go ahead and type it in the chat. I'm going to go ahead and put you back over. Nope, I'm not going to do that.
Now can you hear me?
Now we can hear you. Go for it.
Like I said, I really didn't mean to do that. I bumped it, but anyway, and I got in late, so I didn't hear anything. Anytime that you go to a doctor to do a blood test and they tell you what your testosterone levels are supposed to be, are those numbers real or are they not? What does that really mean?
Yep. So that normal lab. So
Yeah.
first of all, they may just check a straight testosterone without the free and the sex hormone binding globulin and all the estradiol. So the range is 200 to 1,000. So I would argue that they might tell you that you're in that ginormous range, but it doesn't tell you if you're optimized. And unless they ask you how you're feeling and do a symptom evaluation, it's incomplete.
Okay. All right. I guess that's it for now anyway. Thank you.
Thanks, Gary. Who's the next caller?
I've
Okay.
got a I've got a question if nobody has a question.
Yes.
Where should you start? So old guys like me, over the age of 50,
Yeah.
they understand that there may be some things that we are just not the same at that we were anymore, right? Do I
Mhm.
go to my primary care physician? Do I
Mhm.
start here? Where do we start
Yeah.
to get the best result?
So I would like to answer your primary care physician, and if you have a good one and you like them, that's where I would start. Unfortunately, I'm often disappointed at what we find with the labs doctors do, the time they spend with you. So if you don't have that, start at like a course that takes pride in doing a full panel of labs and talking to you and understanding what your issues are. Like I said, we had a patient coming in 4 pellets That wasn't his problem at all. His levels were fine. His symptoms were not low testosterone. It was Lyme disease. So you've got to have somebody who can tease out, what are we actually treating, and is this the right approach? Because again, if they would have given this gentleman testosterone, his Lyme would have gone undetected. His symptoms would have amplified over time. And he, I don't know, might have had some estrogen problems down the road. So the right treatment for the right person.
How essential are having all of these tests versus, because I've been to my doctor for this before, and they just pulled a PSA and a testosterone. Oh, it was fine. It was 758. Your PSA was fine.
Yeah.
But I still have symptoms.
Yeah. So yes, here's one of the basic mistakes that medicine makes is they think that the visit is the product and they don't realize the importance of the lab interpretation. So if somebody comes in and talks to me, the most important part of our exchange is two parts: me understanding what you're coming to me for, and you understanding my vision, my Rosetta Stone of interpreting the labs for you and making my recommendations. So at most medicine, they don't ever do that second visit, which is against their model. You would think that they would want to, but they're having someone call you and say your labs were normal, click, and they take 3 seconds to look at them. So they're not incentivized to do complete lab panels for you because they don't recognize the value of that lab interpretation, and that patients want to know that's the most important part.
It's a good point.
Yeah, that's really where, and sometimes walking through the labs, I actually get a lot more out of patients about their symptoms. Oh, yeah, I'm having this that they didn't think was related. So it's that back and forth dialogue of getting to know you and you getting to know what we're looking at that we really start to tease out what's going on. All right. I really think testosterone replacement in men at the right dose, the right time, the right route, and the right monitoring can be, I don't want to call it the fountain of youth, but is very anti-aging, is very gracefully aging, giving you more longevity. It can be life-changing. So I would highly consider it. And yeah, it's good stuff. The last call for questions. Thank you all for being here again, spending your Monday nights with us. Every Monday at 6 o'clock, we do a topic like this. We do a deep dive. It's more than we can get to into the office in every individual visit, but this is an archive on YouTube. So please share the links, subscribe to our channel, invite a friend to come. And if you have any suggestions for topics, drop those too. As Matt is now on the team and helping you find out about all the things that we're doing. And while you're at it, if you could give us a 5-star Google review, we would really appreciate that if you haven't yet. Google has hampered us and handcuffed us since the beginning, and that helps us break their algorithm and beat them at their own game. So if you can take 2 minutes and give us a 5-star review, if we've helped you out, we'd appreciate that. All right, everybody. Thanks for being here. We appreciate it. We'll see you next time on What Your Doctor's Not Telling You.